really with oncology, I think the point to keep in mind is that nobody expects you to be proficient in the nuances of staging of different cancers or subtleties in the differences of treatment approaches for various cancers or choice of this drug versus that. It feels like a different language to many, and I understand it. Really, when it comes to oncology, and I alluded to this earlier, unlike heme, it's not so much about arriving at a diagnosis. With oncology, it's more about, okay, for a patient with this diagnosis, are you familiar with and can you provide risk factors, screening recommendations, and best steps for initial workup? That is crucial for the practicing internist. In addition to that, there's some important elements that I want you to be familiar with as it pertains to complications of cancer, a basic overview of cancer therapies and the different types, and this has been really an area of tremendous advance over the last decade, and then some selected complications of cancer therapy, including some of the sort of buzzword side effects that you should be very familiar with certain drugs. So we'll start with just a few basics on cancer epidemiology. In terms of incidence, the most common cancer in women in this country is breast, followed by lung and then colorectal. And in men, it's prostate, followed by lung and colorectal. And in terms of mortality, lung cancer is the deadliest cancer for men and women, followed by breast and prostate respectively, and then colorectal as third. So we're going to do a brief review of common cancers. The breast cancer section will be a little less brief just because breast cancer is everywhere. It's everywhere on your board exams. It's everywhere in the community and in practice. And so you'll need to know a little bit more about breast cancer than some of the others. But you can see here what our topic is. And again, there's a fair number of slides and there's a lot of content here. And the content in these slides serves two purposes. One is for me to refer as I'm talking to you this morning, but also for you to refer back to later. And so there may be some slides I don't spend a lot of time on, and that's by design because they're in there for your later reference. So I don't want you to feel overwhelmed at how many slides there are to go through. I hope that you'll thank us later. So what should you know for each major cancer type? As we discussed a little bit, risk factor screening, how they present, initial workup, and then basic overview of management. So we'll start with breast cancer. So as we discussed, it's the leading cause of cancer in women in this country and second leading cause of cancer death. So what about risk factors for breast cancer? So a personal history of breast cancer or benign breast disease, such as atypical ductal hyperplasia or lobular or ductal carcinoma in situ, early menarche, nulliparity, and late menopause. Basically, anything that increases endogenous estrogen exposure can increase risk. Increasing age, family history, inherited genetic mutations such as BRCA1 and 2 and others, and moderate to heavy alcohol intake. These are all accepted risk factors for the development of breast cancer. So let's talk for a minute about these hereditary breast cancer syndrome. So about 10 to 15% of all breast cancers are hereditary, defined by a specific gene. And out of that slice of the pie, if you will, about half of those are related to BRCA1 and BRCA2. The BRCA1 gene is on chromosome 17, the BRCA2 gene is on chromosome 13. And what's probably most striking about these mutations, their claim to fame, or I guess in this case their claim to infamy, is just their striking penetrance, just how high the lifetime cancer risks are with these genes. So compared to the general population risk of the selected cancers you see here, BRCA1 and BRCA2 significantly increases a woman's risk of developing breast cancer, as high as 70+% with BRCA1, 40% risk of ovarian cancer compared to 1% in the general population. And then as you can see, there's also elevated risks that are relevant to males, such as prostate cancer, male breast cancer, and pancreatic cancer, though not as strikingly so. When should we think about testing our patients for BRCA1 and 2 or other germline genetic mutations? We're looking again for red flags, and which in this case is seeing breast cancer or other cancers at a young age, seeing multiple members of the family develop cancer, or an individual patient having multiple occurrences of cancer. That's when you want to at least think about referral for genetic counseling and testing. And there's very defined guidelines from the National Comprehensive Cancer Network that you can refer to be sure that your patient is eligible. So screening for breast cancer options include what you see here, self-exam, clinical breast exam, and then most importantly, mammography and breast MRI. The details of mammogram screening are controversial. There's multiple societies. They all have recommendations that are slightly different from each other. As you can see here, the ACS, the U.S. Preventative Task Force, they disagree on interval. They disagree on when you start and when you stop. And so really, we all might have our own personal biases as far as what we do in our practice, but for the purposes of your board exam, I would encourage you to focus on the common ground where the guidelines agree. So what you see on this slide does not necessarily reflect my own personal practice or recommendations, but for your purposes, for a test, this is what I would consider as the right answer, if you will. Screening mammogram every 1 to 2 years from age 50 to 74. Mammogram has much less utility, but should still be considered for women under age 50 or greater than age 74. Again, this is consensus guideline agreement. And breast self-exam and clinical breast exams have not been proven useful, I put proven in quotes, useful for preventing breast cancer for your purposes for this exam. A couple of considerations with mammography. COVID vaccination. And a substantial minority of women causes axillary lymphadenopathy that can persist for weeks, if not months. So be careful when you're timing a mammogram.